Recording in progress.
Great. Good morning, ladies and gentlemen. Welcome to our ninth edition of Superstar Sundays. We have with us Dr. Ashwin Bava, who's the director of Bava Hospitals, his surgical services at the new hospital he's built, and Dr. Vinayak Mishra, who are going to moderate this session. I'm going to hand over to Dr. Bava to take it further for this hour today.
So thank you, Vishaka, for the kind introduction. It is my absolute pleasure to have part of an actual superstar, Mishra and Dr. Supe sir, who is a legend in academic surgery. And I'll directly hand over without wasting any time to Vinayak to introduce Dr. Supe sir, and let's just get things rolling.
Good morning, everybody. So it's a privilege to introduce Dr. Avinash Supe sir, one of India's most respected academic surgeons and medical educators. Dr. Supe is Director of Clinical Governance at Hinduja Hospital, Consultant GI Surgeon at Zen Hospital, and Professor Emeritus at National Academy of Medical Sciences. He previously served as Director and Dean of Medical Education and Major Hospitals for the Municipal Corporation of Greater Mumbai. A distinguished surgical gastroenterologist and pioneer in medical education, he has held several prestigious leadership roles, including past president of the Indian Association of Surgical Gastroenterology and founder director of the GSMC FAMER Regional Institute. Dr. Supe sir has authored 10 books, over 345 publications, and delivered more than 675 presentations worldwide. He is recipient of the prestigious Dr. B.C. Roy Award, among many national and international honors. Today, he will be speaking on the highly relevant topic, AI for surgical education. Over to you, Supe sir.
Thank you, Vinayak, for such a generous introduction, and I'm really honored to be here with the AWR super surgeons. Thank you so much for making me part of this. And I would first be talking about the surgical practice, and then what is the role in education, teaching, and training. So thank you so much, Dr. Patankar, Vishakha, of course, the whole AWR team, so many of my friends, office bearers, Dr. Bava and Dr. Mishra. And thanks to my friends who helped me in my journey of AI. Now, if you just go in the PubMed and publish and write down AI and AWR, there are currently only 46 publications. But if you type AI and hernias, there are about more than 550 publications. And they are mainly in last 5-7 years. You know, the whole concept of AI has come into this. Now, for many, AI may be very not so they are proficient in that. So I would like to begin with a very simple thing. AI has two basically types. One is discriminative type of AI, which differentiates one thing from another, like what we use in Digiatra or what we use in various like Google Map and all. And secondly, generative AI. Now, discriminative AI works with various machine learning and deep learning, where you can diagnose a pneumonia from chest X-ray, you can predict a sepsis risk or stroke recovery. And this was used extensively during COVID, where people started using this extensively in medical records. The generative AI came in 2022-23, where it started creating content, text, images, speech, any structured data. And that was very much useful in education. And then the medical text generation and clinical documentation was one of the way. And that came the large language models, narrow language models, agentic AI, and now we are talking about the quantum computing. So the whole world has now changing with AI. Now, what is its impact on surgical training, teaching, and practice? So let's begin with first practice and then see if the practice is changing, how we have to change the education. Now, let's talk about clinical decision-making, how AI has done. I will do only briefly because I do not want to, because this is a huge topic. Now, if you really see, there has been a conceptual change in the decision-making from biostatistics to AI. Now, previously, we used to have a biostatistics as our foundation. We used to talk about p-values, probabilities, we used to talk about multivariate analysis, RCTs, and that was the reason why I used to make a decision making. Now, since AI has come, the whole thing has transitioned to what is called as a pattern estimations. We are talking about now personalized risk benefits. We are talking about precision medicine. We are talking about dynamic sequential decision making. So what data was small, we have converted into a large data. And that's what is the decision making, what has happened. So look at some of these papers which come, from predict decision to perform surgery in hepatic echinocosis. Now they are validating the predictive models and pathways to assessing surgical risks in echinococcus. In fact, if you really see this paper of clinical decision making, ML models demonstrated strong discrimination power to preoperative identify patients high risk of developing bile leaks postoperatively. And same thing with 3D visualization, surgery became very easy. And that brought the whole concept of radiomics, where we are now using more and more radiomics for quantitative analysis of medical images data and then extract the imaging features. And if you really see, it causes lot of help to you to really make a diagnosis and treat. But because you are all AWR surgeons, I'm going to speak about what changes it really made into AWR. Now, this was a systematic review which came in Artificial Intelligence in Surgery Journal in last year. And it said AI used in abdominal wall reconstruction, and they took many papers into consideration. Now, what did it really use for AI? It used for mainly few things. One is predicting hernia recurrence, predicting complications, preoperative planning, and answer patient questions. These are the 4 areas where they found this to be useful. Now, predicting hernia recurrence, this was optical compute-based markers. They called it as OCM, optical biomarkers. And they said if you understand the optical biomarkers, then you can predict the incisional hernia formation. So they took, this was a paper from Talwar from Philadelphia, 212 colorectal patients. Preoperative CT scans were segmented into various linear, volumetric, and textural features. And they really took out or extracted 279 features. And what they created were optical biomarkers. And what did they really do? They took out features which are normally considered, something like visceral adipose tissue. And they considered the outer aspect of the body wall skeletal musculature and inner aspects. And they found that this was a significant OBM, like abdominopelvic visceral adipose tissue, abdominopelvic skeletal muscle tissue volume, and pelvic vat volume to pelvic outer. And they said these were increased into all this volume pressure as a salient pathological driver. And ML models, that is machine learning models, using these optical biomarkers are highly predictive of the incisional hernia development. So wonderful paper, actually all of you should read. This was another preoperative computer tomography morphological features. They really studied this same time, somewhere in hernia 2022. They also looked at this machine learning and AI, and they tried to look at this clinical, radiological, and anatomic expertise. And then they tried to also say that they also had so many patients, and they looked at widening of the rectus complex, increase in the visceral volume, and body wall skeletal muscle atrophy. Now, these are many times, if you put through the machine learning, probably they give you much better kind of an understanding. The next thing is, many of these AI models will analyze your investigations. They will predict difficulty, guide you on port placements, based on the rectus placement and your sensitivity. It will help you to see where we should really put the mesh and where to put the placements, and layering of tissues, dissections, and steps of surgery. Now, preoperative planning, there are very few studies. Apply AI in preoperative planning. This is not still developed very well. But I'll make you go through this paper of clinical biomechanics. This was a wonderful paper in 2021. Now, what did it say? It created a concept of grip and grip. I'll talk about it in a minute. So what they did a bench test with low cycling loading. That means they give dynamic intermittent strains resembling cuffs, post-operative cuffs. And they applied it to the pre-operative CT of patient abdomen at rest and during the Valsalva's maneuver. And they created abdominal CT scans, resting as well as Valsalva's maneuver. And they considered the models of tissue elasticity, mesh placement, and fixation of point distribution. And they considered these pressure curves with the bench studies, and this was wonderful. And after that, they really looked at the segmentation and spatial displacement. Now, many times you find there's a hernia, but they found out where there is a maximum amount of pressure and whether you are going to get benefit with putting a mesh. And they created these two concepts, CRIP, that is called as the critical resistance of reconstruction towards impacts delivered by pressure, that we call CLIP. And the GRIP is achieved strength of planned or completed reconstructions. And they said that this ratio is very important. And then they said incisional hernia repair targets relatively this biomechanical stability of the abdomen. And GRIP values influence the factors assessed with the bench test, and bench test calculate preoperative critical resistance. And postoperative CRIP and GRIP ratio predicts excellence 1-year outcomes. And this matrix enables randomized trials, technical innovations. Now, that was their paper. Now, this was used as a concept, and there were 2 papers came in hernia 2024. And what did they do? They used this concept and they said biomechanical calculated repairs improve patient care and they show reduction in the recurrence rates. And this is another paper where they use 3 years GRIP as a useful tool. And it very says that 3 years follow-up of a GRIP concept, where open prospective registry were biomechanically calculated abdominal wall repair for complex incisional hernias. So they brought into the practice. Another concept which came with AI is ventral hernia volumetry, which was only done with the help of Tanaka index and all. Now we are doing it with ventral hernia volumetry. And they started doing image-based deep learning models for predict surgical complexity and complications in AWR. This was the JAMA surgery paper in 24-25. And what did it really do? It used deep learning, analyze preoperative images to predict operative and postoperative outcomes. And it also predicted whether you would need a component separation. Now, many times I feel we open the patient and then decide judgmentally whether this patient will require unilateral TAR or a bilateral TAR. Now, all this can be predicted if you analyze the CT scans preoperatively, and it outperformed expert surgeons with accuracy of 81.3%. In fact, they used those models and they showed that this is little better for surgical site infections, pulmonary failures, which are very common after a very tight AWR, and complexity. Intraoperative decision making has also been changing with AI. Now, 3D modeling and intraoperative guidance is very common now. What is called as, this is a kind of a lever which we create with 3D modeling, and then we can use this model during the surgery. We can keep it by the side. Now, this surgeon is operating by the side and then he's operating. Another surgeon, if you really see, he has cut the lever. This is all on HoloLens, or this is on augmented reality, where he would like to keep by the side when he's operating. So he's operating on one side and he's visualizing all those vessels. Now, this makes his surgery very easy, and he knows exactly personalized anatomy of those vessels. And now he is using his lap or robotic instruments to do this surgery. In fact, if you really see this, AI can be navigation through robotic surgery, and we can now know which layers you want to go. Many times during hernias, I've seen somebody goes into a slightly wrong plane and the whole mess really occurs. So all that can maybe avoided in future with a proper kind of an AI. Now, if you really see many of these studies, intraoperative guidance, people are using this for various levels of surgery, whether using CUSA or anything, you can use this intraoperative guidance. And donor evaluations can be done with AI, and you can really conclude whether this is really possible or not. Then fire flow fluorescence, which is of Da Vinci, has been very much useful. It's like ICG, and you can assess the tissue perfusion and location of vascular, whether it's a gallbladder, whether it is intestinal anastomosis or brain, you can really use that. In fact, deep learning models can find it out whether when you're doing a laparoscopic cholecystectomy, in fact, they can intraoperatively make that difficulty and then use this analytics for grading the operative difficulty and time. In fact, this is very well known now that computer does it outperform the human vision, especially with programs for critical view of safety. There are now various apps which can really identify and you can get a feedback. Search Smart was one program which is capable of accurately detecting and positioning anatomical regions of LC. They took 93 LC videos. This was another paper from Taylor and Francis, Computer Methods. And they use CNN and DeepMind for best binary models to classify gallbladder difficulty. And they really found out how we can really find out, record, and legally be sure about what we are doing. Then machine learning models outperform guidelines in predicting colloidocholithiasis. Many times you are in a stuck, and many of these papers are trying to say that. You can do what is called as a cinematic rendering. You can create an image of pancreatic tumor instead of CT. This helps surgeon to understand whether it's a borderline pancreatic cancer, and then you can operate very easily. You can create what is called the intraoperative holographic navigation. Again, you can create a CBD and it remains image with you with 3D printing models. Post-operative decisions have been now used, like AI has saved lives in ICU. This has been well proved during the COVID. Clinical decision supports and glucose and ECG have been used. In fact, as I said, many algorithms have helped to save the livers. Predicting post-operative complications. This was used especially in AWR and may suspect predictive surgical complexity and occurrence of SSI in patients who underwent AWR. In addition, it established many factors like age, BMI, diabetes, emergency, ASA class, and predicted the type of mesh, size, and site of mesh placement as an important predictor of an outcomes. These are all very well-known papers in the whole thing. Chat functions and patient education. This was another area where perioperative assessment and many questions related to that can be answered with the patient. All routine chatbots delivered patient questions, but you could have a narrow chatbot, agentic AI, where you can really make patients answers. You can get an idea what to talk to patients, especially a young surgeon, he can really get. For a senior surgeon, it may not be necessary, but a young surgeon, you can answer with language quality and supplementary questions. It can also predict the donor liver allograft steatosis. Now that when we are going from surgical practice AI, we must be very clear about that translate AI decisions into human decisions. Don't totally believe in AI. Do not say AI said this. Convert it to your opinion and use it. Don't blindly follow AI. That is my first advice to all of you. There are a lot of ethical issues with AI. There's a privacy, bias, and many times the AI can be wrong. You have to really understand AI can be wrong. There are a lot of model issues, and therefore, unless it is validated in your own settings, do not use AI for clinical practice. Final decision should be of human. Don't forget, human is most important in the decision making rather than automotive AI. You cannot transfer your responsibility to machine, and that is where something, car accident. Now, sometimes, this is always there. You are driving a car. You cannot blame car model for the accident. Ultimately, you are responsible for car accident. Same thing if you're using AI, you are responsible, and therefore human decisions are very important. So let's come to the topic, what we are supposed to talk today on training and teaching. So how do we use these advances in training and teaching of our surgeons? How should we really train the new generation of our residents? How do we teach the new generation of our surgeons? If the whole surgery is changing with AI, and I think we need to also change our surgeons, how they were traditionally taught. Now, if you really see impact of AI on health professional education, it is on practically every aspect of AI. That means it is on the curriculum, it is on the teaching learning methods, it is on the education management, students monitoring, and also how do we assess our students on various surgical and non-surgical techniques. Now, emerging technology in education, I'm sure many colleges I go across the world and I see the technology has been used. There are better and better equipment, and people are now don't have one laptop. Many of them would use their mobile to connect to TVs and screens. PowerPoint and keynotes, simulation labs have become a very big thing for making a teaching. 3D printing, has come up in many hospitals, like even my own hospital. We find many times, like neurosurgery and others, people are doing 3D printing. Virtual reality, augmented reality, and mixed reality are coming in a big way. So people started using Chat GPT, DeepSeek for the purposes of their making PowerPoints. But remember, I would advise you to not complete. They may create something, a platform for you, but don't completely believe on them. Sometimes they can wrong. They can give you wrong references. So you have to be very careful what you are really using this. How many of you have performed your first IV line, intubation, or delivery on a real patient? And I think most of us did it. And that is what exactly why simulation was born. All of us did it first on the real patient. And then you realize that we have a guilt of causing damage or some pain to the patient. And that was the reason why simulation-based training came. And simulation-based training today improves patient safety, clinical competence, and system performance in a high income setting, something like this. So if you really see, there is a low fidelity simulations like simple 3D models, animal models, human cadavers, simulated standardized patients. And then came the high fidelity, screen-based simulators, procedural simulators, virtual reality. And to this now, they have added AI-based patient-specific kind of a pathologies on which the people learn. So what has AI done to simulation? AI in simulation involves using AI techniques to create realistic, data-driven simulations that mimic the real-world environments, behaviors, and complex systems. So there are different kind of simulations, predictive simulation, interactive simulation, behavioral simulation, and immersive simulation. Now, predictive simulation means AI forecast possible outcome based data outcome. To give you an example, I will give a little example outside the thing. That weather forecasting, you can really use it. AI for science, predicting infectious diseases, monsoon outbreaks. We did one study where we tried to look at last 50 years of Mumbai rain, and we say what is the kind of dengue outbreaks, big data analysis. This was a paper which was published from KEM. And then you realize that we could now know what is the rain pattern and what is the dengue kind of an outbreak which is going to happen. Same thing can be done for surgical diseases. You can have a big data and you know what kind of outcomes it is going to be predicted. Then artificial intelligence is obstetrics, predicting preterm birth, estimated fetal weight, predicting success in the vaginal delivery. Then interactive simulation allows you real-time interaction with users and simulated environment. Virtual training for pilots, surgeons. Now, if you see, this is one where AI Harvey cardiopulmonary resuscitation simulator. You have a patient where you can create situations like shock. You can create a complex kind of a situation. And then you make students work on it,
The group is going to be understanding the same reality. So now the instructor can really focus on how to manage a complication. Nothing ever has provided that level of information. It's not a textbook, it's not a video, it's not a PowerPoint presentation that's going to give you that kind of understanding. CA Healthcare selected shoulder dystocia as the first scenario on Lucina AR because it's a rare complication of delivery, but it's one that's difficult to manage. You have a number of options. You need to think fast. Seeing the anatomy, seeing the progression of the baby in the birthing canal, and seeing where the shoulder gets stuck is going to be very helpful to understand how to fix it. Seeing them in front of your very eyes as a student is like a revelation, right? This is the future of healthcare education. Really beyond the spectacular of that experience, there's an educational purpose that we're fulfilling. And that
now look at this, the way students learn. Now you can create any situation. You can create a large hernia and then you can ask students to really work on it, and then how do you really take inverted sutures, how do you really take, and then you analyze it and give students the personalized feedback. Then behavioral simulation, where you can focus on simulating human or animal behavior in an OT. This can be easily trained now. Then immersive simulation is you're combining VR and AR for AI for highly immersive training, like military drills. Now look at this. This is from our GSL lab, Rajmandri, where you have a room like this where you can create heart, you can create abdomen, you can liver. Students can lift it up, they can study the anatomy, and then they can really learn. So that brought to the various types of simulation, data driven simulation, agent based simulation, hybrid simulation, and digital twin simulations. What do you mean by that? Like AI processes historical data to generate accurate simulation outcomes, especially, for example, the accuracy of appendicitis. Or you can use AI for crowded casualty, to patient flow journey. You have a crowded casualty, you have crowded kind of a patient flow. How do you really systematize it? And it will really tell you, okay, this is empty, here you can do first, you can go, and that will reduce the load on the hospital. It can create a role of 3D printing, I already told you, and then you bring the component of mixed reality. On one hand, you have real environment, other you have virtual environment, you mix it together. And also, when you use extended realities, that when you all together in a low or high immersion.
Placement. The ureter is closest to the pink zone. The rectum is closest to the red zone. So our green zone in the midline is the one with the greatest safety zone with both the ureter and rectum at safe distances.
Well done. In what direction would you place the suture? Speak the color of the correct arrow.
When we're placing sutures, our area of maximal control is the entry point. So we're going to put our entry point from lateral to medial, as that's going to be closest to the ureter.
Now look at this girl is trying to learn how to prevent ureteric injury while doing rectal dissection and abdomen. And now she's practicing it in augmented reality. And unless she becomes proficient, she's not being allowed to touch the patient. And that's the privileging. Today we are talking about robotic privileging for students, surgeons. This is where a simulation data, though privately stored, can be of a great use to the hospital boards to make a decision. And this is where HoloLens was there. Now HoloLens has been replaced, but there are a lot of now Indian companies which are coming, which are providing you with these kind of virtual realities, and they can make you assessing and learning attitudes of communication. You can create a liver like this very easily. You can hold like this, and you can know where is the tumor exactly, and you can really treat the patients. You can really create different colors. You can stretch it, and you can really see the way it is. In fact, you can use it for lap myomectomy. Many of you must be doing lap myomectomy, so you can really know exactly where is endocrine. So if you really see this technology and the newer methods had changed the surgeon's competence, there have been enough publications now say that this has improved the teaching for the students. Another thing which has come is what is called as the digital twin simulations. For controlling, you can create a human kind of a twin. You can create your own twin, with all your attitudes and your parameters, and then you can try it out everything. That's what I think many people in India also have created now, a human twin. And then you can start working and you can put your all data. And if somebody has a diabetes which is uncontrolled, then you can create a digital twin. Like this has been done in our Mumbai. I think there are many centers are using digital twin to control data. Another importance which has changed is virtual patients. The scripted virtual patients, AI-based interactive patients, and avatar-based patients. They are the three things which have come. Now, scripted patient is you can talk to patient about a history, and patient will give you feedback. Hello, my name is so. Then you say I'm so and so, and then they'll say how can I help you. You can go on talking on cognitively, and at the end it will analyze and it will tell you, okay, these are the points you missed in history, and students can learn on their own and they can learn. Then avatar based virtual patients are something. They are narrow agentic AI, where they will speak on a particular thing in a very depth, something like stopping an antidepressant. You can talk to a patient. Then suspected bowel cancer consultation and type 2 diabetes. You can think about how to do remote consultation. They speak like human, and they have a lot of focused knowledge in this area, and they give you feedback. What is most important in AI today is analytics, and that is very important. Skills are not acquired by pushing a button. Remember that. Everybody has to learn skills by achieving competence. So you learn it by different models. So initially you have motivated and you are a novice. Then you become competent and proficient by critical thinking and continuous learning. And over a period of time, you become self-improvement and you creative solutions. But you must remember, in a college, first 4 phases, when somebody is going, you require a good feedback from a mentor. Now, previously, we used to observe, assist, perform under supervision, perform independently, and perform. Then used to do that. But today, there's concept of deliberate practice which has come, and this is done with AI-based kind of a thing. So, to give an example, learning laparoscopic cholecystectomy started in 1990, and I'm sure people started using models like this. These were simple models made of cardboard, and people started using this, and on our home TV and all started using it. So how do we know how much one has learned? That's the question. You may have practiced for 100 hours, but how do you know you have learned? So then came the whole concept of synchronized video motion analysis. They started doing learning analytics, and that was a wonderful paper from one of my postgraduate who went to the Imperial College, Krishna, and he did ocean. So what he did really, he found out how is your right and left hand is really working. And then that gives you idea that my left hand is weak, so I must do those exercises more so that I can become a better laparoscopic surgeon. So with this, if you do then there's an improved performance with learning analytics. And that's where you find people have to do now their analytics. So now they went into the AI mode. So in AI mode, they went into deep learning image analysis. They tried classifications, detection, and segmentation. And what did this paper do? They did videos of people, of their residents, and they just put it to the CNN, what is called as the convolutional neural model. And they found out, is he able to detect anatomy well? Is he able to do instrumentation? How is he able to do? Is he able to do action recognition? And what is his phase? And see, to give you an idea, for example, they would recognize the presence of a tool in a surgical field, and they will find out how is the movement of your hook, or how is the movement of your forceps, how is the movement of your needle holder, and are you able to do it properly, or there is a lot of shake in that movement. Now that will help you. In fact, they can find out a score between novice and expert, and that novice has a lot of shaking hand while expert has a very stable hand. And that's where the education management has come into picture. You have AI based learning management systems which do adaptive assessment, predictive analysis, gamification, text to audio, and they give you personalized learning path. Now there may be many students, but it will give a chart for every student that you have done good in this, you're not good in this, you need to do more exercises on this, and that helps the people to really learn more. So I'm sure I can go on talk on this for hours, but AI as a partner, there are many benefits. Personalized learning paths tailored to individual student needs. Simulation of rare cases. Many times you have a tumor. Nowadays they call it as a patient specific simulation. Today, all the world is talking about, if you have a tumor which is abnormal, with the gel and all, they would create a tumor, they will put it into the body, and then they'll ask you with robots or with the model to operate on you. So you know exactly where should we put my ports, how long I should put it, what is the complex situation, and then they will see your performance, and then you can try it in your patients. Accessible 24/7 learning. This AI is available to you 24/7. It gives you an objective assessment of skills, how good you are. They will put numbers, they will put pathways, they'll give you tracking, reduced administrative burden. All this is done automatically, so the teachers don't have to do. They can only review it, what has come as a result. What is the threat? AI is not without threat. There's a dependency risk. diminished critical thinking ability. There's a Harvard paper which has really told us that you may have diminished critical thinking. Skills can get atrophied, especially many things I feel nowadays, many students, 83% of students today in most of the world use AI for their assignments, which is a really problem. Black box problem. We don't know how AI is working out. It doesn't give out reasons unless you ask for it. Sometimes it gives. There are a lot of ethical consideration, privacy, bias, and accountability, where to use and where not to use. So most of the universities, most of the organizations are now putting their guidelines for use of AI for education or practice. Even India has now a policy of AI healthcare. There are so many universities have now university policies of using AI in their education and educational equity. Technology is not accessible to everyone. So what are other cons? Data and privacy, as I told you, bias and accuracy, unethical outcomes, then computational cost, inaccurate. Computational cost is very high, and interpretability of AI decisions. These are the problems with AI. So if you're asking somebody to develop a skill, traditionally it was structured clinical reasoning, progressive skill development, deliberate practice, and mentor-guided learning. This is what many of us got learned through that. With AI supplemented education, now you are thinking about pattern recognition. We are talking about accelerated knowledge access. We are talking about simulated experience. And we are talking about algorithmic guided learning. This is what is the change which has made it. And so we have overdependence, skill depth, clinical intuition atrophy, and less human judgment. So what are the lessons learned over years? AI augments but not replaces a surgeon. AI makes life easy for teachers and students. Trust AI but verify. AI can be wrong. Ethics first and technology second. What AI promotes is personalization over standardization. And many of the publications have now AI intrusion. So disclose it, whatever you have used for AI. And empathy cannot be automated yet, but there may
I think we lost him. His connection is weak.
then augment with AI assisted learning with human oversight. Then collaborative phase, partnership between student and AI. And most important is a critical evaluation where you should learn to override AI. Like we say, clinically override AI. So we should really know. So what is future of AI surgical education? AI offers unprecedented opportunities to enhance surgical education. Surgical education has completely changed with AI in most of the world. And in our countries also, it will change. In many centers in India, now they use virtual reality, AI-based education. Threats exist but can be mitigated through thoughtful integration. Ultimate goal is physicians who work effectively with AI while preserving human judgment. And the question is not partner or threat, but how to ensure partnership while minimizing threats. So I think if you see school classes, this was the study of my granddaughter who was taught AI ethics in class 9. I feel AI literacy and ethical use of AI is essential for every student, and so is for surgical residents. So there's a data which gets converted into information. When you get a meaning to it, it becomes a knowledge. And when you add experience and analytics, you get wisdom. And that's what AI does. But initially, we began with AI resistance. We were opposing AI. Then we have started accepting AI. Then we have started integrating AI. And today we are in a phase where we're integrating AI into this. But what is more important is we should learn to override AI. I should be able to say, okay, this AI output is wrong. I don't believe it for the patient. I will have my own clinical judgment, which is better, or intuition. Now, if you come to that stage, I think that is what is most important for journey of AI. So AI has come to stay. AI has potential to improve surgical outcomes. AI augments training. AI has some flaws and issues, and AI will not replace surgeons, but it will augment their performance. So to conclude, AI in education offers unprecedented accuracy, adaptability, and efficiency. However, it can be wrong at times. So AI and computing power continue to advance simulations and become more realistic, predictive. All of you should remember, learn AI, but verify what you are really doing. And ultimately, the last thing is, when a flower does not bloom, you fix the environment in which it grows, not the flower. I personally feel if a student is not doing well and he's not training properly and he's remaining incompetent, we have to fix the environment which we are making him learn. So if you improve that environment, I'm sure the students will learn better. Thank you so much. And I'm sure we will have a discussion on this with two stars, Baba and Dr. Mishra is there.
Sir, I must say this has been an expositive description of AI use in surgery, and perhaps one of those presentations which you can reference to with AI use in surgical education. It is absolutely a full exposure. I would have a few questions for you.
Sure.
As an academic surgeon, as a pure breed academic surgeon who would be on board to review journal articles, how do you foresee AI use, and how do you kind of look at AI use right now for anybody who's using AI for writing or
Fine,
manuscript
sure.
preparation?
See, I've been on many educational journals as editorial board and also on many as faculty. So many institutions today, even if it's a simple assignment, they put it to AI scrutiny. You know, like I get in Tata Institute, when I'm doing, I get a report, alternative report, or copy leaks report saying that this is 10% and all. And many people would accept about 15% acceptability, not more than that. As far as journals are speaking, reviews, 23% of reviews in medical education were AI based, initially. That now we have been asking many of the reviewers not to use AI because that is not worth it. But many people use AI. If you are disclosing it for the purposes of making an image, or you're using for references, I have another YouTube talk. You can really see my YouTube talks, but I have recently given a talk in Vellore, CMC Vellore, on ethical use of AI in publications and medical education. So we had really talked about it, what is ethically acceptable and what is ethically not so acceptable. And today there are university guidelines which are being very clearly. So I would say searching properly literature, customized search, then summarizing it sometimes, then you are using it for references, properly creating small images, AI is okay. But if you are writing the whole article as a de novo content generation, I would say it's not worth it. It is not allowed, it is unethical, and there may be many mistakes. And many times when you are searching references, they are very wrong. If you're using a free version, many times I find they are right. If you're using paid versions, many times, they are also making difference between paid and free. And many times people using the paid versions, they get a proper references. So you have to write a specific on a prompt. Everybody should learn prompt writing. That you should give me searchable in PubMed references. And if they are wrong, then you scold your AI model and they will give you proper references which are searchable.
Sir, another question. But before that, I must say it's a pleasure to see Dr. Ramanna on a truly superstar Sunday live here. Hello, sir.
Hi.
So one more question, sir. You said in your talk that one should not, get influenced by clinical decision making and use AI for clinical decision making. But I would like to add one point. If you see Open Evidence, the software, this is a US website, and interestingly, they came up with this data where 65% of US physicians are already using Open Evidence. Open Evidence, for the sake of audience, if I tell you, is like the go-to AI for physicians anywhere, where they have been able to get everything that's on PubMed into this website,
Sure.
and you could ask it clinical questions and it would come up with true references. So what's your take on this?
Fine, sure. So today you find clinical key AI has there, Willy AI is there, up-to-date AI is there, Open Evidence is there. And practically I use many of these just to, but I would never believe it unless it clinically I'm confirmed about it. I have to my clinical mind has to satisfy. If I particularly see today, there was a very nice understanding. I don't know whether you have listened to one fellow was there from Vienna. He talked about you have to really see what is the risk of clinical decision making you are doing. If it is a simple kind of a task, you are summarizing and all, and you are talking to patient and all, then it is not much of clinical risk is involved. And there is no automotive kind of an AI. For example, if AI is going to take control completely, I would be 100% no. If AI is going to give me a advice on a critical step, it would be augmentary rather than I would completely believe AI. I would make AI as an augmentary to me rather than I will completely believe AI, especially for critical tasks. If for mild tasks, okay, I may believe blindly, but I will not really today believe anything by given AI blindly. I would test it. I would ask, having a meeting and then do it. I think we should all follow this, even if you say 65% of the physicians follow evidence, but they should convert those AI decisions into human decisions. I said that one word, if you remember, convert all AI decisions into your human decisions. You should be agreeing with that. Then only we would do that.
I invite Dr. Ramana if he has an input or a question.
Thank you. Really amazing talk. Enjoyed every moment of it. I have a couple of questions. I'll start off with one for you, sir, which is that amongst the various AI platforms that are available, which ones would you say are relevant and appropriate for surgeons, specifically with regard to whatever we tend to use AI for? Obviously, you would say that different people use AI in different ways,
Fine.
but why don't you just take us through?
Sure. Fantastic. Very nice, Ramana. Thank you very much for asking this question. There are two types of AI models. One are what we call the general models, and there's the academic models, what we call academic chatbots. Now, general models like, say, ChatGPT, Gemini, Microsoft Pilot, Claude, or Canva or something. Now, what has happened, they are trying to become narrow AIs. That means what they are developing the expertise in a very specific group. For example, Canva Pro will create images or invitations. Then you have Claude, has so many types of versions. One is better in thing. So these are all general chatbots. When you go to the academic chatbots for various academic activities, you have now specific kind of an chatbot. For example, a Research Rabbit will give you a customized paper search. Some of these papers some of these things will give you a specific kind of an task. If you have, you can use these narrow AIs, which will give you. Now, what is coming out today is for surgeons a specialized narrow kind of AI. For example, I showed you that cholecystectomy AI app. It will only tell you whether this is the critical view of safety is correct or not correct. Or it will many times will tell you, okay, this is your clinical decision making, especially for, say, rheumatoiditis. So what is happening today, many specialties are working out on a very specific narrow-based AI. Now, what is important today, if you're using a general purpose surgeons, I'm sure you can use, but don't ask ChatGPT about your narrow decisions. It may not have been trained, but if it is trained and validated on that particular kind of an area, then it will give you a better answer and better complex answer at your level. A ChatGPT will go to PubMed and give you answer. But a narrow AI, which has been specifically done for that, it has been fed with, say, 1 lakh images of cholecystectomy critical view of safety. Now, that is much better than ChatGPT. So if you have a specific task, so that is where the world research is going on. Now, world research is creating narrower and narrower kind of an AI models. And today, I'm sure AWR will have their own narrow band images, which will tell you, okay, whether we should put mesh where or what can we do. So I hope you understand. So you should do that research and use it appropriately.
Right. Thank you. I have one question for Ashwin Bawa and Vinayak, which is that We tend to use individual chat platforms, AI platforms, but we hear also of people who are able to engage multiple AI platforms together using a Mac Mini, and it sounds like something pretty far out. Do you have any insights about that, and do you do any of it?
Vinayak, you go first, or do I go first?
You can take that question.
Yeah.
I'll add
So
to it.
there's something called chatplayground.ai. So it's mind-boggling. Don't pay for it, but I do mention it in my talks, where you could get outputs out of four agents together. So it uses the latest versions of all. So in case you want to engage in knowing the output out of all four together, you could get a subscription and try it. I've done that for an essay that I had to write for the Indian School of Business. But I must say that if you have to choose one for your general purpose work as surgeons and something more intelligent than ChatGPT is just like your personal assistant whom would you give these tasks, just ring these things, put this Excel sheet properly. I'd use it for general purpose, but if you want to really use something very, very intelligent, my go-to platform right now is Claude. I vouch for it.
Ravina, can I answer this question?
Yes, please.
In 2000, we started getting TV channels. And that time we used to subscribe Star Plus and Sony differently. And we used to get. Then we started getting aggregators. So something like Tata Play Binge, I'm give you an Indian example. I don't know about, say, Australian example. But today, Tata Play Binge gives you all this. So same thing has happened today with all this, something like Perplexity. Perplexity will give you 4 or 5 kind of major chatbots, and it will give you one answer. So what are people now doing is, and I'm thinking what future will be, there'll be a speciality-based aggregator kind of a chatbot, with the chatbot which will answer all questions which are related to, say, AWR or with HPV surgeon. And I think we are moving towards it. So in next 5 years, I see a lot of the chatbots will come, which will have an multi-aggregation of the chatbots. And that is something where you can give one subscription and then you continue with your ChatGPT Pro or something. One you keep of the large model and one as your specialty aggregated model, which would probably the way to go. And as you said, currently the whole market is loose, Anybody is using anything for anything, which is not to be true. We have to use specifically for this. So this is the future which is likely to occur.
So looks like the future is whatever amount of money you earn, half of it is taken by government, and now the other half will go into subscriptions.
See, and ultimately, you must realize who is making money. It's all the tech billionaires are making money out of you. See, ultimately, the global north tech billionaires are making a lot of money out of you all paying through this, right?
I must
just to add to it, data is a currency now.
Yes.
So we need to really think about something. I had a chat with some of the people who are into development of generative AI models. And they actually told us that if you're signing up for free subscriptions, then we have the authority to use your data. So then your data privacy is at risk. So you should consider one model and then you should consider subscribing to it. Because as soon as you are into a financial loop with them, then you are signing an agreement with the company that they will not play with your data or they will not share your data that you have shared with them to other hospitals or other people.
True. Very true, Vinayak. And see, when you are paying the kind of a model, then the data many times remains in your own cloud. If you're doing a free subscription, it goes to the central cloud. And then we don't know whether it is used or not. Where it is used. And that's where the DPDP coming, we have to be very careful. And sometimes we'll have to make a choice of what to subscribe. And I think that's where I think Dr. Ramana's question is so relevant that we have to make choices, how much subscriptions we have to do and what kind of models we have to use.
So, Dr. Supe, there is a question by Dr. Sai Bharat. He has asked, we are doing VR imaging integrating AI in hernia surgery. Most important in this study is analysis of data. Data should be minimum 200 cases for AI to be reliable interpretation. His question is, should we do a common registry or do a collaborative study for better results?
You can do common registry, but you have to use some filters to anonymize the data. When you are putting that, there is some kind of filters which take away the patient's name and identifiable kind of thing, especially when you're using CT or any other thing. So there has to be filters from your side before you put it to the registry, because we don't know, once you put in registry and put it some model for analyzing that data, you may have a privacy break, and that may not be acceptable. So you can do, now there are many people are coming with these studies where there are many centers are coming and putting data. I think what we need to do is, there's a filter, I forgot that name, there's something by which you take away that identifiable all that data and then you put it. That's the only advantage, I would say. That is the only precaution you take when you're doing a common registry.
So one more interesting question. Do you think future surgeons will be trained differently because of AI compared to previous generations?
They're already being trained in many places. Simulation is the commonly used, more commonly with learning analytics. Most of the people are using learning analytics today, and patient-specific robotic. Especially look at robotic training, how it is done and how it was done previously. Today, now you require privileging, you require credentialing, and now today you require so many hours of being introduced with your analytics, and has been already done today. It is not like only judgmental like what used to do. So more and more of these will come. I think the students will have to maintain their e-portfolios, logbooks, their learning analytic kind of and data. And many hospitals, when you go abroad, will ask for that data. That is what is happening today. Many centers you go, they will ask for your portfolio data. Okay, how many hours you spend, what are those results, can you show us your learning curve? And then only they will, and then that's where the decisions are made about proctoring, proctor gap, all these issues are coming up. For example, like Baba, you did this surgery and you are coming to me as a hospital. I would have my own judgment. But then if I'm not confident, I will put a proctoring gap, something like that. And then I'll make you learn. And that's a very different world. I think we are still not there, but many hospitals in India already started working on this.
Sir, one more last question from my side. This is personal. 375 publications and going. Avinash Supe, who starts in say 2026, and the Avinash Supe with with 375 publications before 2026, can he 10x his publications if he starts using AI, ethical use of AI? And do you encourage people to use, there are tools available which can help you, write papers and other things. Do you foresee that happening?
The question is yes, no doubt about that. See, in 1983, when I had my first publication, I had to use typewriter.
Yes.
And I had to type it 6 times with so many corrections. And I could do only one publication in 1983. That time it was to get it published and going in references was such a thing. Today, I think with I'm not saying only AI, a lot of digital also help has come. Your support systems have improved. So publications can be definitely high. But what matters is, are you contributing a message through these publications, or you just recording it? I mean, if you say, I would like to publish more where I'm contributing some positive messages which are practice changing messages to the people, rather than just recording publications.
So the difference in level is that I was born in 1982. So amazing stuff, sir. I would also take the privilege of doing the vote of thanks for today, since it is just 11 and we'll be ending the presentation. It has been a marvelous session, sir. Lots to learn from an actual giant. Dr. Ramana's presence, is deeply encouraging. His insights are always amazing. Vinayak, you are a younger brother and a partner in crime. Thank you, the AWRSC community, Vishaka, Deepak, and everyone on the back end. Thank you, Doc Plexus team, for really making this interesting and a truly worthwhile session to moderate. Thank you, one and all, sir.
Yeah,
Finally,
don't forget our little star, Dr. Vishakha Kalikar. You know, she's
I said
amazing.
Vishakha, sir. Yeah.
Sure. Okay. Thank you. Thank you so much.
Thank you.
Thank you so much. Thank you,
Thank
Dr.
you, sir.
Ramanna, especially for coming. Thank you so much. Okay.